Good evening. I'm Beth Emery. I'm past president of Alamo Breast Cancer Foundation. I'm ABCF's alternate to the National Breast Cancer Coalition Board, and I was the Alamo Advocate Program director last year. Welcome to ABCF's 28th annual Alamo Advocate Program, created in partnership with the founders of San Antonio Breast Cancer Symposium to enhance the educational and network building experiences of patient advocates at SABCS. We are pleased to have all of you here in person and those who are online virtually. And we're really glad that we have one of the largest scholar classes in our history. We have 36 scholars, 30 are sponsored by Alamo Advocate Program, 4 by Teresa's Research Fund, and 2 by the Metastatic Breast Cancer Alliance. They come from 16 states plus Puerto Rico and 8 countries. We also have 7 volunteer advocates serving as mentors, and they've been terrific. This year's Alamo Advocate Program is dedicated to the woman who founded both ABCF and the Alamo Advocate Program, my mentor, Dell Eastman. We are also delighted that SABCS dedicated the session this morning on advocacy to Dale. Now, one of the things National Breast Cancer Coalition and Alamo do whenever we have meetings is start with a moment of silence, and Jolynn Collins, one of our scholars, will do that.
In 1997, Sylvia Capolino hosted friends to discuss moving forward with an organization to serve women living with breast cancer. She and a few others attended NBCC's summit that year and were inspired to go back home and found the Breast Cancer Coalition of Rochester, revolving around 3 goals: education, advocacy, and research. Sylvia served as the first chair of the coalition's board of directors. The organization has grown over the years to include 27 counties in western and central New York. Her goal was to see a world where the organization would no longer be needed, a world without breast cancer. As she put it, then and only then will we close our doors and go home. During her more active years, she attended many professional conferences on breast cancer, participated in Project Lead, and served as a research grant peer reviewer for the Breast Cancer Coalition of Rochester Research Board, as well as the National Breast Cancer Coalition and the New York State Breast Cancer Network. She later relocated to Tennessee, but her passion for breast cancer advocacy remained. She started Tennessee Breast Cancer Advocates and worked closely with organizations in her area to continue pushing for the passage of the Metastatic Breast Cancer Access to Care Act, including submitting a letter to the editor to the Tennessean asking for senators and representatives from Tennessee to co-sponsor the bill. Sylvia passed away on August 8, 2024. Please join me in a moment of silence to remember Sylvia. Thank you.
I will be the moderator of the panel tonight. Before we get started, though, I want to acknowledge our sponsors who make this program possible. Their logos are shown on the screen. The premier sponsors this year are Genentech, Pfizer, Menarini Stemline, Lilly, Novartis, and Cyber Media Productions. Collaborating sponsors are Daiichi Sankyo, Merck, AstraZeneca, and Natera. And contributing sponsor is Exact Sciences. Okay, now we'll start with the program. I'll tell you a little bit more about why I deserve to actually be sitting in this chair as opposed to just giving you the details. I am a 17-year survivor of HER2-positive breast cancer, and thanks. And I'm a project lead trained advocate, which means that I've spent a week learning about the science of breast cancer. I've also served on peer review and programmatic review panels for the DoD Breast Cancer Research Program, and I've worked in an advisory capacity for Common Sense Oncology. I was also, as I said, pleased to serve as the director last year of the Alamo Advocate Program. We are so pleased that the planning committee got Alamo back on a seat, an advocate seat, and that was Mary Jimenez, who is the head of our program this year. Those 4 patient advocates on the planning committee have ensured that we have patient advocates participating in virtually every program this year at SABCS. And you can't have been, it's fantastic. You can't have seen them all, so be sure and watch them, because I mean, Marilyn Miner is just a rock star. This evening, our mentors will spend about 10 minutes talking about what's hot from today's sessions, and after that, we will give the audience time to ask questions. Now, remember, when you're thinking of your questions, it can't be about a personal diagnosis, and you get to ask one question and then move to the back of the line. I'm going to start by introducing the panelists. First, Dr. Jessica Trevino Jones, who many of you know, is an associate professor of oncology at the Long School of Medicine and founder and director of Care Clinic at Mays Cancer Center, UT Health San Antonio, MD Anderson. You're going to have to work on a better acronym for that.
It shortens down to CARE.
Oh, CARE, so we'll just call it CARE. She's built 2 innovative clinical programs across the UT system with a focus on patient identification, novel care delivery with enhanced cancer risk assessments, and concurrent innovative interventional strategies for patients at higher risk of cancer. Second, we have Dr. Maira Caleffi, who's head of the breast center at Moinhos de Vinto Hospital in Porto Alegre, Brazil. She's a technical consultant for the World Health Organization, a member of the board of directors of the Union for International Cancer Control, and president of the board of directors of the Institute of Governance and Cancer Control of City Cancer Challenge, Porto Alegre. That's in Brazil. She's also involved in academic research, teaching, and patient care activities through a multidisciplinary team. Let me get the right one here. Next is Dr. Tari King, who actually was the moderator for a panel I was on earlier. She is the newly appointed Chief Surgical Officer for the Cancer Service Line at Winship Cancer Institute, Emory University, and Emory Healthcare. She serves as chief of the newly formed Division of Breast Surgery in the Department of Surgery at Emory, and as surgical director of the Winship Glen Family Breast Center. Her clinical and research interests span from breast cancer prevention to the molecular genetics of tumor progression, while maintaining a focus on optimizing multidisciplinary treatment strategies to improve patient outcome. And last but not least, Dr. Neil Iyengar is co-director of breast oncology and director of cancer survivorship and associate professor of hematology and oncology at the Winship Center in Emory. Dr. Iyengar's research program investigates interventions to improve metabolic health as a strategy to reduce breast cancer risk and mortality. His group is testing the anti-cancer effects on structured lifestyle interventions and pharmacotherapeutics that treat metabolic disorders to improve the effectiveness of cancer therapies. Prior to joining Emory, he was the founding director of the Memorial Sloan Kettering Healthy Living Program. And we'll start with Dr. Trevino Jones.
Thank you. So today we were asked to share what we found to be exciting, during the sessions today. And I think there are 2 of us on this panel. We are, or all of us, are very aligned with wanting to make sure cancer is cured, but we also understand that part of the journey, part of endocrine therapy, all of that which comes around, there's a lot of talk about obesity, and not just anything. There was a lot of discussions today about GLP-1s. So I will share that I found it to be very exciting. The abstract presented this morning at our poster highlight sessions, showing us that the use of GLP-1s in women who have a history of hormone-positive breast cancer can take these medications and effectively lose weight. Another abstract that was presented shared that by taking the medication, a woman's overall survival was improved. There was also some controversial, or I guess it's more surprising information shared about how it impacted side effects. And so between these different abstracts, I found them to be the most exciting, knowing that when I'm speaking with women in clinic and we're talking about how hard it is to take hormone therapy, whether it's from the existing side effects as it is, when we talk about weight gain that can happen on them, I was very excited to hear this information, to see this data, this real world data, showing that yes, overall survival can be improved. So it's not a medicine that I think we should be fearful for when we think about weight loss. But it's equally surprised with some of the side effects that were worse for women who took them. And those were what I found to be very interesting this morning.
Dr. Caleffi?
Yes, good evening. I'm so happy to be here, and something that was not written on my CV, that is one of the most important things that I've done in my life for almost 35 years, is that I've been the founder of the largest organization, 20 years in one, another 10 in another one, organization of advocates and patients in Brazil. So we are the largest foundation, is a federation of NGOs only dealing with women's cancer, largely in breast. And this year, I'm so happy that we have one representative of our advocacy, Gabriele. It's the first time that a Brazilian comes to join you. So I think that spent all my life dealing with breast cancer patients as a doctor and also as an advocate. But what I was very interested today from the general session was this thing about escalation and de-escalation of procedures. Because I come from a time at Guy's Hospital in London that I trained there, that we did very, very radical mastectomies. And we were kind of competing who did the largest axillary clearance, how many nodes we're kind of talking about. That is the de-escalation that really worked in my life and for my patients, in benefit of my patients, because we stopped seeing all those arms since, I think, let's say 15, 20 years ago. But having said that, I don't think that we are ready to de-escalate everything as now it's going on. I don't like it. And I want to hear from you guys, because I think that I know how bad or how fearful and dramatic is when we say to a patient that the disease that's supposed to be cured came back because of a lymph node, because of or a small DCIS in the breast that was conserved. Thank God that we're doing breast conservation more and more. But I don't think that we are ready to de-escalate. Only maybe in very low DCIS, over 70. But I am almost over 70, and I don't want to be down-treated, you know. I just feel that we need to think through this, because I don't know if you see patients that, for example, they have radiotherapy, conservative, because of conservative treatment, and then they have another lump in the same breast. How difficult it is to have a mastectomy and a reconstruction in a breast that had radiotherapy. It's very difficult. We have to take tissues from somewhere, and it's long, very, very difficult. So it's not like, oh, never mind, it's local regional recurrence. That's I do mind, and if I can prevent that, so we are not so ready for all this de-escalation. This is what I feel, and I would like you to know, to say what you feel as patients. And the other thing that I like very much is how we're going to make a tumor that is cold hot. Oh, I like that, you know? I like that, because we know that there are better treatments for hot tumors than colder tumors. And was this presentation about maybe giving 2 or 3, 4, I suppose, sessions of radiotherapy locally before the Pembro? I thought that was clear, very clever, but that is like for later days.
Dr. King.
Well, I appreciate all those comments. And what I'll say is that, I understand that the word de-escalation can be a little loaded. And I really think that what we're trying to do is we're really trying to right-size therapy. The same each individual patient needs the right-size therapy for them. And it's very easy to feel like bigger surgery might be better. But unfortunately, in most cases, it's not. Or fortunately, let me say that. I'm a surgeon, though. I like to operate. I'd like to have that much control. I don't have that much control. So it's really the biology of the breast cancer. It's the biology of an individual woman's diagnosis that's going to really impact whether there's a recurrence, whether I perform a lumpectomy and she has radiation, or whether she has a mastectomy. And that's really what I think is the best thing about this meeting, is it brings all of us together, all of us from different disciplines: surgical oncology, medical oncology, radiation oncology, our scientists, our advocates, and we really learn together what are the drivers of this disease and what do we need to be thinking about to right-size treatment for each of our patients. So we've heard a lot about, yes, de-escalation primarily in the sense of how much axillary surgery do we need, how much surgery do we need to do on the lymph nodes. And absolutely, as a surgeon, I don't want to give anybody lymphedema or put somebody at increased risk of getting lymphedema. And we've seen an incredible evolution in our management of the axilla in the last 2 decades. We saw Dr. Giuliano win the award yesterday morning for his pioneering work in sentinel lymph node biopsy, which has spared many, many women the need to have complete axillary node dissection, not only in women who have negative nodes, but also in women who have a limited number of positive nodes. We don't dissect the axilla anymore in those cases. And then now, clinical trials showing us that there are some patients where we don't need to do any axillary surgical staging, and outcomes are just as good. They are not inferior, and that's what we have to be clear. We're not trying to set you up or set ourselves up for failure. We're trying to set everybody up for success, to live as long as you're supposed to live, with the best quality of life that you can have. So I think it's really exciting how, again, we continue to see this interplay between biology and treatment and disease burden, and we get to work together to really right-size the treatment for all of our patients.
Great, thanks. And Dr. Iyengar?
Well, great. Good evening, everyone. Can I just start by saying what a cool event. Thank you for having me. This is the first time that I'm doing this. The assignment, as I understood, was to identify sort of the 3 highlights that we found most impactful today, and I'm going to talk about 3. One of them is really because I want to get your feedback. But I want to loop back around to the GLP-1 topic because, of course, that's also my area of passion. And we did see some exciting data. I completely agree with the comments that were raised. Yeah, let's go back just to last year because we saw GLP data that was presented here last year as well. So in the post-breast cancer diagnosis setting, I think we all know that weight gain is a major problem, particularly on endocrine-based therapy. So it makes sense that if we have an effective weight loss strategy, combining with endocrine therapy is attractive. But our group at FASCO last year showed that the weight loss with GLP-1 receptor agonists is only around 5% when you're taking hormone therapy, which is in complete contrast to the 15 to 20% weight loss that patients without cancer achieve on these drugs. Then we saw data from MD Anderson presented last year here as well, which also demonstrated only about a 4 to 5% weight loss. So this raises the question, should we be dosing these drugs differently? This morning we saw some really interesting data that again, dose likely matters in terms of the amount of weight loss that we're going to achieve, but that dose may be limited by the adverse effects or side effects of these treatments, as was already highlighted. And so I think we need to think very carefully about what therapies we're combining the endocrine therapy with. We have very limited data in terms of combinations of weight loss therapy with chemotherapy. And there I would be concerned about safety issues. The last thing I would want to do is delay chemotherapy administration, or immunotherapy is another area of unknown, because of adverse effects from the weight loss therapy. We have more safety data, observational safety data with endocrine therapy. And so there I think this is an attractive area to use the weight loss medications, but we need more data in terms of how we should be dosing those medications. So what I take away from the current state of data when it comes to weight loss therapies is that it's important to have open conversations with your oncologist, and you want to have conversations where the oncologist or your treating physician is certainly open to using these therapies, but you also want to partner with either an endocrinologist or a primary care doctor who is also open to exploring different dosing strategies in that setting. All right, that was the weight loss therapy. The second area that I thought was particularly of interest, and this is thematic for the whole meeting, is some of the new data that's coming out in terms of oral SERD therapy, both in the early stage setting as well as in the metastatic setting. And I heard that you all talked about lidERA yesterday, so I won't get back into that. But today we saw some updates for the phase 2 ELEVATE trial, which is the combination of elacestrant with multiple different molecular therapies. And I think what's exciting about what was presented today is we saw data for the combination of elacestrant with everolimus and elacestrant with capivasertib. And this was in essentially genomic all-comers, so you didn't necessarily have to have a specific mutational alteration for the everolimus arm. And what we saw there in terms of these combinations, firstly, was that the combination was safe and well tolerated. And secondarily, what we saw was that the median progression-free survival appears to be better than what we see in other trials that tested traditional endocrine therapies, AI, for example, with these molecular therapeutics. So I found this to be very promising. This is phase 2 data, so it needs further validation in the phase 3 setting, which is happening as well. But I think we're now moving forward in terms of combination strategies with the oral SERDs. As you all know, we have the availability of elacestrant and now imlunestrant as monotherapy in the metastatic setting, but we can do better, it appears now, with combination therapy with molecular approaches. The third thing that I'll highlight is, I'm selfishly bringing this up because I want to hear what you all think, and that is that we saw the patient-reported outcomes data from DESTINY-Breast09. And just as a reminder, DB09 was a trial that was testing upfront use of trastuzumab deruxtecan in combination with pertuzumab in the first-line setting for metastatic HER2-positive breast cancer. Compared to the standard of care, the Cleopatra taxane HP regimen. And as you may recall, we saw really remarkable improvements in progression-free survival when you use TDXD in that upfront setting. But the key question is the trade-off in terms of adverse effects worth it? And what we saw in the patient-reported outcomes data was that there was an equivalence in terms of PROs between the TDXD pertuzumab arm and the traditional Cleopatra arm. And what's interesting in the Cleopatra approach, as you may know, is we drop the taxane, we stop the chemotherapy once you've achieved either a partial or ideally a complete response or even a stable response, and continue that maintenance Herceptin pertuzumab. So one would hypothesize, since you're dropping the chemotherapy, maybe the patient experience or quality of life is worse if you're continuing the TDXD sort of indefinitely. So I thought it was very interesting that the PROs actually were equivalent between both approaches, and would love to hear what you all think about that. So I'll stop there. Thanks.
Great. And do any of you have comments on what one of your other colleagues have said? No, okay.
We're going to let you guys direct.
You just want the questions. We're ready to open the floor for questions. Remember, you get to ask one, then you go to the back of the line. Don't ask about your personal diagnosis. And we will monitor the screen for questions coming in from our virtual attendees. When you speak, state your name and your organization first, and I will be watching the time because we're live streamed. We have a hard stop at 6:45, and I'll let you know when we're getting up to the last one or two questions. Okay, we'll start over here.
Hello, my name is Annie. I'm here on scholarship with Twisted Pink. My question is about CDK4/6 inhibitors. We've seen a lot of data about the efficacy of them as a first-line treatment. What I'm noticing as someone who's had metastatic disease since I was 26 years old, who's had great success over the past 10 years on CDK4/6 inhibitors, I'm not included in any of this data. So when and how will we begin to see real data about the efficacy of CDK4/6 inhibitors in young patients with metastatic disease?
Question.
That's a great question.
Yeah. So if I can start by saying, well, congratulations on your control of disease. That's wonderful to hear. I think there are certain studies right now that with CD4/6Ks that have looked at younger women, namely premenopausal women, and we've talked about the efficacy of those drugs. Right now, what I'm thinking of off the top of my head is ribociclib, and thinking about how this has been shown in different settings, both metastatic as well as how we can improve the reduction of cancer coming back when we partner it with hormonal therapy after treatment. And I would love to also have my colleague down the line share their thoughts as well. But in particular, having women have control for a very long time is still not, it is the exception to the rule, not necessarily the norm. So the amount of women for us to be able to all come together to study that particular question will always be challenging, in that what a beautiful story, but how rare it is to find that.
Yeah.
So instead, what I would maybe like to highlight and say is that I am encouraged that even with younger or premenopausal or more aggressive disease, is a testament to your own success, CD4/6Ks are still showing value and control of disease. Please.
Yeah. Can you hear me? There we go. So I would also like to echo my congratulations. That's really phenomenal. You know, I agree. I think that what we need and what I think we're starting to do is really understand what we call sort of host factors, and age is a really important factor when it comes to testing the variable response of our therapies. What's interesting is that there's been more of a focus on, for CDK4/6 inhibitors, on understanding whether or not we can de-escalate in older populations. But I think you raise a very important question about, in younger populations, should we be doing something either more intensive or different? What I'll just highlight here is that if you look at all of the CDK4/6 inhibitor trials, there are subgroup analyses that have tried to stratify by age, and there are only a handful of patients, as you rightly point out, who are in that 20s age cohort. And when you look at the premenopausal trial for ribociclib, MONALEESA-7, you do see a consistent benefit for that younger population, but we have to keep in mind that median follow-up time is less than 10 years. And so for a 26-year-old, in 10 years, you're 36. That's not enough follow-up time. So we need more follow-up time. And this is where I think the real-world data sets will be helpful. For palbociclib, for example, we recently saw the Henry 3 trial, which was a real-world, well, I should call it a trial. It was the Henry 3 study, which was an observational study that looked at patients who were age 75 or older, and there saw a very strong signal that there was an overall survival benefit despite that older age, for using palbociclib. So now the question is, can we replicate that in younger populations, especially since the real-world data set will span more than a decade of data? So I think I don't have a good answer to your question, but I am encouraged that we're using real-world data sets more and more, and I think that will help us understand the longer-term natural history for young-onset breast cancer.
Awesome. Thank you.
Next one.
Hi there, Elisa Shirago. I'm an Alamo Scholar, proud Alamo Scholar, as well as a volunteer advocate with the IBC Network Foundation. And so I'd like to give a little feedback very briefly and ask a question about the downsizing versus right sizing. One of the things that we're seeing in the IBC community, and we're actually bringing together researchers, advocates, clinicians, is that there have been doctors who say, oh, you got a PCR, well, we don't need to give you radiation. Or very, very often, we're going to do a sentinel node because we're concerned about your risk of lymphedema. The problem is with IBC, there's 40% false rate with sentinel node. So how can we make sure that right sizing and get the word out, particularly to surgeons, get the word out that, in our case, right sizing is going full bore?
Yeah, absolutely, and appreciate those comments. And it's great that there are communities pulling together around IBC. And we do need to be clear that the data that supports downstaging or de-escalation does not include women with inflammatory breast cancer. And when I was at Dana-Farber, we also were running a trial trying to see if we could improve upon the sentinel lymph node identification rate. Can we get better data to suggest that we could do axillary staging and not a full lymph node dissection to determine response to treatment? And we did have much better results in our cohort, over the last 5 years than those earlier studies which have been published, which are not great. So I think that as systemic therapy improves, and we do see higher rates of PCR, and we've learned a lot about optimizing our technique for the sentinel lymph node procedure after neoadjuvant chemotherapy, because we've had all this attention on all the trials trying to do that in the last decade. So I am hopeful that we will get to the point where we do have data to support sentinel lymph node biopsy as a staging procedure in IBC and not have to go all the way to a lymph node dissection just to prove if the disease is gone or not. I think, as you said, we're a long way from not needing post-mastectomy radiotherapy. We're a long way from feeling comfortable not doing a mastectomy. We'll need lots of trial data to support the safety of de-escalation of breast surgery, but I think we will see de-escalation of the axillary surgery in our lifetime.
Thank you.
We have a Zoom question from our virtual attendee. Is there any information on GLP-1 use with triple-negative breast cancer?
Yeah, so when we look at some of the data sets that I mentioned earlier, the first thing to say there is, of course, in the triple negative setting, we're not using hormone therapy or endocrine therapy. And so you do see higher rates of weight loss in that setting. But interestingly, you still don't see that up to 15 to 20% weight loss that you see in non-oncology populations. So whether or not that's because patients have previously received chemotherapy, and one of the things that we know about any chemotherapy is that chemotherapy worsens metabolic status. There have now been several studies which demonstrate not only weight gain and increased waist circumference, but hemoglobin A1C gets worse, insulin gets worse, lipids get worse after chemotherapy. Now, chemotherapy can be life-saving, so we have to balance the risks and benefits. But what I'm trying to say is that most or many cancer therapies worsen our metabolic status. And so we're sort of in a deeper nadir that we have to climb out of. So perhaps it's a dosing issue with the GLPs, or maybe we should be using other therapies. So for now, what we're doing with the European Society of Medical Oncology, we're drafting guidelines for how to use these drugs, both in the preventative setting and in the post-diagnosis setting. And we're cautioning that if you're initiating chemotherapy, whether it's for triple-negative breast cancer or ER-positive breast cancer, we wouldn't recommend starting a GLP. If you've been on a GLP and the dose is stable, it may be okay to then initiate chemotherapy without making dramatic changes in the dose of the GLP. If you're initiating immunotherapy, which of course we use for triple-negative breast cancer in many instances, then it may be safer to hold the GLP-1 receptor agonist because we really don't have data in that setting. And the last thing I'll say is that I just want to plug a clinical trial, a multi-center clinical trial that is ongoing right now for triple-negative breast cancer. It is not testing a GLP-1 receptor agonist, but it's testing a novel small molecule called a MET-AP2 inhibitor. And this is a drug that was originally developed for the treatment of obesity. And we learned that it has anti-tumor properties and can counter the ill metabolic effects of chemotherapy that I just mentioned. So this trial is testing the combination of eribulin chemotherapy plus the MET-AP2 inhibitor for patients with metastatic triple-negative breast cancer. It's called the ARETHA-1 trial, and if you Google that, you'll find more information about that trial.
If I can also add, because not just weight loss, but there has been some controversy in using GLP-1s with some published data this 2025. If we use this with a triple-negative breast cancer and chemoimmunotherapy, are we reducing our chance of getting PCR? And so that has been a concern in the medical community. But something that I found really enlightening and wonderful today was that there was data presented from a cohort of patients, a minority community with Hispanic patients. 61% of the study were Hispanic. Hispanic patients as well as Black American patients, while not the main population in this study, have more obesity, different social drivers of health, different adjacent to cancer disorders such as hypertension and hyperlipidemia. And this abstract that was presented this morning showed that there was not a change in PCR. It did not reduce PCR for Hispanic patients that were given or that were on GLP-1s while also receiving their chemoimmunotherapy. So in addition to the weight loss aspect and metabolism aspect, which is very important, the other question of, is it even safe to do this with triple negative while we're giving these therapies? I think it goes to show there's a lot still to explore, and I don't think they're totally out yet, especially as we look at the other parts of the body that they are treating, which is adjacent to cancer.
We'll go over here.
Hi, I'm Karen on a surviving breast cancer scholarship, and I'm also with Living Beyond Breast Cancer as well. So my question, you were asking for feedback about using Enhertu in first line, and so when I was at ASCO learning about Destiny-09, my first thought is like, why in the world would you use Enhertu in the first line? Because I started with basically the patina trial drugs without the chemotherapy, and I got almost 3 years out of that, and now I'm on Enhertu, and I would say that the patina trial, I had no side effects that affected my quality of life at all, and now I'm on Enhertu, and yes, and many other people I know on Enhertu, there is quality of life issues. And so, you know, unless there was some really aggressive cancer, I mean, I think you know, at least with patina for me, I didn't do the chemotherapy and had a very good result. And I mean, the years that you got out of patina were equivalent to what you were getting out of Enhertu. So I don't really understand. There was a lot more media attention, it seemed, for Destiny-09, but I didn't understand why. What would be the situations where you would use it in first line? It didn't make any sense to me, given at least the side effects that I'm aware of.
Thank you for that feedback. You know, I think that's really helpful as we try to contextualize the patient-reported outcome data from Destiny-Breast09. You know, I think you raise an issue that I think we're all grappling with in terms of the Destiny-Breast09 data and the concurrent patina data, and that is that the idea of the induction maintenance approach. And for a long time, the only way to do that, as you highlighted, was through the Cleopatra regimen, taxane, Herceptin, pertuzumab, withdraw the taxane and then maintain on HP. And as you mentioned, at least most of my patients also tell me that maintenance period of just HP is a lot better and a lot of quality of life returns during that period. If we add on the CDK4/6 inhibitor and endocrine therapy, as Bettina showed, we can extend that time where people are living a relatively normal life. Well, normal may be too strong, but better than on chemotherapy. And so I think what you're struggling with is what we're struggling with, and that is that in Destiny Breast 09, there were two major findings that were so compelling, and one was that the amount of time, the median progression-free survival on that regimen was far superior to the taxane HP regimen. In addition to that, there was a doubling in the complete response rates. In other words, the tumor completely disappeared, radiographically at least. And so the question I think that's unanswered is, can we try to get that kind of a response by starting with trastuzumab deruxtecan, and then maybe after you achieve a response like that, switching to a patina-like approach where you de-escalate and you go to Herceptin, pertuzumab endocrine therapy, and CDK4/6 inhibitor to sort of consolidate or maintain that impressive response from TDXD. That's sort of conflating these two trials together, and we don't actually have data that supports that approach, but those discussions are sort of happening right now. We're thinking, how can we combine the best of two worlds, which is essentially Patina and Destiny Breast 09, rather than just sort of indefinitely continuing TDXD.
Or maybe skip the induction if you have asymptomatic metastatic cancer, like I did.
Yeah, that's a great point also, because we've seen in the hormone receptor positive setting that it is appropriate in some cases to use endocrine therapy and HER2-directed therapy, and you still get some great responses there because of the crosstalk between the estrogen receptor and HER2 pathways. So I think there's a lot of individualization that we can and should be doing. Thank you for your comments.
We'll go over here.
Hi, I'm Laura McCambridge. I'm very grateful to be here from Australia as an Alamo Advocate Scholar. I've really been struck getting to know all of the advocates over this time, and how brain fog and changes to thinking are often brought up in conversation. It's not really what I'm seeing presented on the AE slides on the talks, and I was wondering if I could get your thoughts on maybe how this AE in particular is being asked about and being recorded, and whether there might be a place for a short global measure of cognition at all in our trials.
Yeah, I would say in particular when we're measuring AEs, when we're measuring side effects, we're using a very common measure that allows us to have uniformity across multiple trials. As such, it really puts the onus on the physician who is with that patient, with that research patient, to make sure that I'm asking the questions that are part of this. But I will say, I agree, I often think too, the way I word the question versus the way it may be interpreted is a problem. I do agree with that, but it is challenging right now, and I would love to hear from my partners on the stage that the survey and the other outcome measures that we try to also utilize and integrate with our patient-reported outcome and quality of life measures, I like to believe are a way to kind of bridge that, which we need to have our CTCAE version 5.0 just there, because that is our uniform across multiple trials, and it allows us to say this is between this. But I do agree, I think a lot about how language and how speaking with people can also take that into consideration. But please, I want to hear what others are thinking too, because we do it all the time, right?
Yeah, I mean, I think that for me, it's two issues. One is how we quantify this, and then two is how we address this, right? And so, you know, as was identified, AE grading through CTCAE, I think, is completely inadequate to truly quantify the cognitive deficits that people experience, whether it's subjective or objective. So then we rely on patient-reported outcome tools, historically the FACT assessments and now the PROMISE assessments and further assessments that are being developed. And you know what I did for quite some time for my patients that were reporting this is I would send them for neurocognitive testing, which what would happen is they would go for neurocognitive testing, Some of them would come back with the evaluation saying that they're perfectly fine and there's no issue, but they didn't feel fine. Or they would go and they would come back and there would be a deficit that was identified, but there was no intervention for the deficit. So then there was really nothing we could do about it. And so just side note, when my mom was diagnosed for breast cancer, I could tell that there was something going on, and I sent her for neurocognitive testing and she came back with no deficit identified, but I could tell that there was some kind of deficit going on, right? So I think that there is, the issue is how we measure it and then how we treat it. In our exercise trials, we're trying to address this through functional cognitive testing. And I think that might be, I think we can borrow from the Alzheimer's research and use some of the assessments that are more functional in that setting to try to match the appropriate intervention. And for now, the best evidence in the oncology setting is to match really exercise. That's really the only thing so far that's been shown to be helpful in terms of cognition. But whether or not there are medical therapeutic approaches, I think we do need to look at dementia and Alzheimer's research to understand how to apply that to oncology.
Something that comes to mind that maybe you just started this conversation and it's going to change how we do this in the future reminds me of there's some new therapies, some targeted therapies that are causing a lot of skin reactions. And because of this, we've really had to partner with a different subspecialist, right, a dermatologist. But we've also reevaluated how do we grade, as we were talking about, how do you grade this outcome? And so using pictures. And so under the picture, with all skin types included, because rashes will look different between different skin tones, this is what the dermatologist recommends for giving if the rash looks like this versus this cream for if it looks like this. So I was sitting in a working group with where we were discussing this, and this is what, as physicians on the clinical trial, we want to be able to provide the patients. Especially after your question and after all of our dialogues, it brings the question, how can we change how we design clinical trials, thinking about that exact.
Can I say something? Look, this is how lucky I feel that came this year. I've been coming to SABCS for 30 years. But this year, to having so many advocates around on the round tables and knowledgeable, and I know that you're investing a lot of your time getting to know more and more. You know that in Brazil, a medical meeting is seen as propaganda for drugs, and patients are not allowed to be. So I talked to Rosanna Ellis, I know most of you know, she's my friend, and we said that we had to partner with Alamo, because I know that you were one of the first one in the US, at least, that started all this movement. And you have to lend how did you manage to do it? Because I see that patients are different in culturally, language. We have so many different aspects. You talked about the tone, and I thought about so many other things that is not only the tone of the skin. But you see, how we're going to keep advancing if we don't know what's out there? Only one-to-one patient, but that's not what the trials say. What is and then we follow the trials. When you do real-world data, or Monday morning when I'll be in my office, doesn't fit, And I think that this is very important to raise this thing about to be more knowledgeable. Patients, they have not the right, but perhaps they should know more about their own disease, and then we need to bring together for this forum, because I think it's an awesome place here.
Thank you so much.
You go to this.
Hi, I'm Sally Wolf. I'm here from New York as an Alamo scholar, and I am a metastatic breast cancer thriver. My question, I was excited to attend the AI session today, and artificial intelligence, not the aromatase inhibitor. I realize in this room, maybe. Unlike every other conference I attend, maybe I should distinguish that. But one thing that struck me, there was a lot of great charts and conversation about maybe trying to better understand whose disease. I was an early stage survivor, turned threat rate cured and then not cured, and maybe better understanding that journey. But what I haven't seen as much of, and I'm really curious to learn more about, is how can we better use AI and all of the data out there to better understand who is going to do well on what treatments? Because once you are metastatic, time is precious. And I've been privileged. I mean, trials were done on bodies that looked like mine. I am 7.5 years on my first line of defense. I just turned 50. I say I'm gonna live to be 88, which is double infinity if you turn the 8 on its side. But I have lost far too many friends, far too quickly. And it feels a little bit like a game of trial and error, and I don't mean to diminish, because I know every oncologist is hoping that the choice that you make for that patient is the right one. But we are collecting so much data. I hope my oncologist is taking data on my super responder class. I keep asking her, I'm not sure if that's happening. Many of us in the room are equally fortunate in that capacity. And I would love to know what you see, whether it's already being done or perhaps is on the horizon, to harness the amazing data that could and should exist to better determine what treatments really will work for each person to give them the same good fortune that I've been privileged to have.
Were any of you in that presentation on AI today?
No,
Yeah, okay, it was great. Watch it. Watch the recording if you weren't there. Carol Boss was our advocate representative on it, and she had some very insightful comments too. What?
Oh, there she is. Hi, Carol.
You were fantastic.
I think those are great comments, and I would just comment that we saw Dr. Sperano yesterday present during the general session. I don't know if it was highlighted here, but essentially taking clinical trial data and using AI for predictive purposes in the early stage setting, right? Benefit of adjuvant chemotherapy or not. So it is being done. I wasn't able to attend the AI session, and I now wish I did, but I'll take a look. But it is being done, but I think you're right that we could be doing this in a much larger scale, and that is also being done. But I think what we have to also be careful about is that these are all learning models, right? And so the data that we feed in impacts what comes out, the output, right? And so one of, I think, a potential trepidation is that, of course, we're here learning about all new therapies that are coming out of the pipeline. And so we don't know the individual predictors and variations, particularly to novel therapies where we don't have long-term follow-up data. So I think, and I'm hopeful that we'll get to a place where AI will help us with treatment selection. But I also think that when we're also on the cutting edge of novel therapies, it still will remain a little bit of an unknown in terms of what are the predictors of response.
If I can go on to, because I will share with you a story that stays with me now when I'm taking into account all this exciting information about advances in technology and AI. In particular, there was this one model being developed to help a dermatologist, I don't know where this is coming from, but a dermatologist see what is the likelihood of something being melanoma. And whenever they looked at the AI model and they were looking and trying to investigate to say, okay, yes, they're at this place, only then later in application they realized, oops, it's not working, because when we built this learning model, the AI took into consideration that most of the pictures we showed it that had rulers next to the skin lesion turned out to be melanoma. Well, yes, because those were the ones that were confirmed to be. So you can see how that can happen. So it is a growing science, one that we need to be responsible about, one that we need to be intentional. And really, it's blending lots of different sciences because it is bringing the bench to the bedside, but putting in that middle man, I would say. And so if anyone else, so we're going to get there one day, I think.
Thank you.
Nancy.
Hi, I'm Nancy Porvu. I am proud to be here as an Alamo Scholar this year, and I am a research advocate from Dana-Farber. I was de novo metastatic ER positive in 2002, and I want to get back to the GLP-1 conversation because I took hormone therapy for 10 years. And over the course of that time, I gained weight steadily. And so I think there's a role for the GLP-1 in prevention of weight gain. And that we're talking about it as weight loss for people who have a weight issue, but not about prevention for the people who are getting a weight issue. I was thin when I was diagnosed. I exercised and I lifted weights, and I had 3 kids I was running after and a busy practice, of my own. And I just gained 30 pounds out of nowhere. So I think there's a role in prevention that we should be looking at. I just want to contribute that to the conversation and hear what you think about that idea.
So that is incredibly well said, and I couldn't agree more. I think that this is, so as we're designing trials in this space, one of the comments that we certainly make is that prevention of weight gain would be a win. I think that what is tricky to navigate right now, and where we would love to partner with advocates as we have our discussions with regulatory bodies and with industry, is what are the appropriate endpoints here? And the path to regulatory approval or label expansion for a GLP-1 receptor agonist for patients with cancer is uncharted, right? In an ideal world, at least in my opinion, cancer would be a qualifying comorbidity to get access to a GLP-1 receptor agonist. But right now that is not the case. And how we get there from a regulatory standpoint, when we ask our friends in FDA and so forth, nobody knows. There's no pathway there. And so I think that we need to partner and make comments like you just made to help design the trials in a way that's meaningful for you. And I think prevention of weight gain is absolutely something that would be a win. So thank you for that comment.
And make it less expensive.
Yes.
Yeah. It's unaffordable for most of people where I live now.
Hi, I'm Ellen Landsberger. I live in New York. I've been living with ER-positive breast cancer for over 30 years, 8.5 of which have been with no metastatic disease. And I couldn't decide whether I was going to talk about exceptional responders or GLP-1s. So I'm going to follow up with Nancy and continue with the GLP-1 story. A couple of things I've heard you say. You were talking about, I wouldn't do this, I wouldn't start the drug with the chemo. I wouldn't start this. I wouldn't do that. And I reflect back this morning with, or maybe it was yesterday. I don't know. I'm confused about the days. What? Yeah, but about the doctor who wanted to do the sentinel nodes, and it was told that was unethical. So I think these things are ethical, and I think we need to explore this stuff. There is a study going on at MSK of using GLP-1s with people starting chemotherapy on endometrial. That I know, because I'm an advocate on that. And so people are doing this, and I've been on, I had an exceptional response to GLP-1s. So on aromatase inhibitor, I lost 25% of my body weight. And that was already when I was a low weight, because I have been dealing with obesity longer than I've been dealing with cancer. So my question then is to you, Dr. Iyengar. I don't know anybody, any oncologist who knows more about exercise, nutrition, and what to do. So would you consider doing something like this? Because I can tell you that all the people who are writing prescriptions for GLP-1s do not know how to use it, do not know how to counsel patients, do not, aromatase inhibitor and GLP-1 is a great way to get osteoporosis. There's a lot of problems with it. You know all this stuff, and I think that it would be wonderful if you would consider doing it well.
Wonderful comments, and thank you so much, and so nice to see you again. I promise I didn't plant her. I worked with Dr. Angela Green at MSK in designing that GLP-1 study for patients with endometrial cancer, and you're right to point out that some patients in that trial are initiating chemotherapy. I do think that's a direction where we want to go, and I'm glad that you called out my comments because I do want to clarify that the comments that I'm making are really directed to guide current clinical practice with the current data that we have, and I think we do have to think about policy statements and broad public health statements. So this is meant to sort of be broad general guidance. But you're right that when I'm sitting in the clinic with the individual patient in front of me, it's a different situation, and we have to individualize our therapeutic approaches. Have I started a GLP-1 at low doses in patients who are starting chemotherapy? Yes, I have. Would I go up on stage and say to people, we can do that? No, I wouldn't. So this is the gray area right now where we don't have data to direct this, and I think this is a huge area where I want to partner with you all to really emphasize what a high priority this is to our partners in industry, to the regulatory partners I mentioned earlier. And we are having these conversations, but they're not moving fast enough. So I think this is an opportunity for us to partner as communities in the research community and the advocate community to really drive home that we need this research and we needed it yesterday. So thanks for your comments.
Well, it's interesting because Angela got back to me against MSK. They asked her, well, why do you have to give the Mounjaro at the same time as the chemo? Let the person get treated and then deal with the weight gain afterwards. And it just speaks to what Nancy was saying, that prevention of this is really, very significant, very important. So thank you. Good
Absolutely,
to see you too.
Thank you.
It's surgery too, right? Weight is a problem if you're going to do surgery. So anyway, it just made me think about the fact that we totally haven't even thought about our surgeons here too, where it benefits them whenever women lose weight before surgery. Am I right, or do you want to comment on that, especially with reconstruction?
I think it should be a prescription for everybody, I think. Because I think that this is why I'm struggling with the cost. Yes, it is true, but I think we have 60% at the moment overweight women in Brazil, 30% obese, declared obese, and there's nothing that we are doing because all this data coming forward saying how bad it is for you, but what they are going to do if they've been like that for 20 years, or if we are becoming, going to your, I can enlist in your list, right? Becoming obese, because this is a type of thing that is happening. So I think that we are in Brazil working very hard on public policy, and it's not there yet, but it's something that we would like your hand.
Yeah, absolutely. And I'll make a comment, and then I'm so sorry that I have to leave a little early, but the last comment that I'll make is, I do, and I'm a huge fan of the GLP-1s, don't get me wrong, but I do think that we do need to be methodical about it because there are very positive psychological effects, but there can be negative psychological effects as well. And when I talk to my patients and we consider using a GLP-1 concurrently with cancer therapy, I have to understand also what are their sources of joy, because there are data to suggest that these drugs attenuate both the highs and the lows. And so I don't want to, in that setting, especially if we're in the acutely post-diagnosis setting, I don't necessarily want to take away or flatline joy. And so I think that's an issue where we need more research, and we need better patient-reported outcomes tools to understand the implications, not just physically, but mentally as well. So with that, I'm going to say goodbye, and thank you very much for letting me participate.
Thank you. Don't forget to be unmiked before you leave. Could be embarrassing. Come over here.
Maybe one last question on GLP-1s. My name is Adrienne Cornwall. I'm here with Living Beyond Breast Cancer, and I'm curious about what the safety data show and your clinical experience with when you're considering a GLP-1s for patients in the early stage setting versus in the metastatic setting, and the time on endocrine therapy and cumulative weight gain, and how you consider those two populations.
Yeah, just before you go, losing weight is been demonstrated that in any setting is important.
Yes.
So how we're going to do this?
Fitness too. Fitness, weight, always showing benefit and improving.
But the therapies are a little different, right, in those two settings. So.
Right. Well, I will say I am a big believer in utilization of GLP-1s to assist with weight loss, knowing that, as was shared earlier, the metabolism in our body does change. A patient's body does change. It changes after giving different therapies. And medical-assisted weight loss has been truly a game changer for so many. And while I'm reassured, because this morning was great data showing that these medicines can be given and not hurt overall survival, which for a long time, we weren't sure if we're doing this, are we hurting women or not? And so I think more of us in the oncology space as medical oncologists will feel more comfortable stepping into this role. But I will share with you some of the limitations that many oncologists, while we're on stage, the surgeons, and that we are doing work in this space. So I think whenever you hear us speak and we talk about prescribing these medications, that's one thing. Mm-hmm. But in reality, there is a big disconnect with the way a lot of physicians, what they understand about these drugs, because they were not trained on these drugs. These drugs have come out and have been approved even while the newest medical oncologists were in training, after their internal medicine training. And we are even now making fellowships, training programs for physicians to understand obesity medicine. And so we have a lot to do even on this, in the inside, so we can support everybody, not only, cancer, of course, that's part of our cure, right? It's wellness, it's whole body wellness. It's really a big part of survivorship. But I think it's also important to say that there may be a day, if you want to talk about this with your oncologist, that you will not hear the same answers, mostly because it was not part of training. And a lot of these medications came out, and the dosing that we're sharing, that is because we're motivated and we're learning about it. But it is still being disseminated nationally and internationally. So I would say, I think your question has now made me ask the question to you, how many people have even been offered that in that clinic space? And it's showing that as oncology providers, as surgeons, as medical oncologists, as those of us that want to work in survivorship and pre-vivorship, which is one of the big roles I hold in my cancer center, it is reevaluating that which we consider to be our job, that which we feel is in our scope to prescribe.
Thank you. We'll go over here.
Hello, my name is Oksana, and I'm here with the Breasties. And while I did gain 40 pounds as a 25-year-old on hormone therapy, my question is not about GLP-1s, but so valid, it happened to me. I noticed that in 2024, the words oligometastatic and curative intent became like buzzwords in the metastatic space. And I noticed that this year there wasn't a lot of discussion about oligometastatic and curative intent. And I actually was considered oligometastatic by my care team, and kind of on a whim, my care team offered a liver excision to remove the metastasis surgically, and that's been followed by my care team, but ultimately they don't really know what to do with me at this point. I'm wondering, as I've met more patients that have been on the same first line of therapy, sometimes second line of therapy for 10, 15, and 25 years, shout out to Heather, I'm wondering how the surgical and the medical oncology community is approaching those oligometastatic patients and what curative intent looks like going forward.
Sure. Thank you. Thank you for that question. And I'm glad that you had an excellent liver surgeon. So certainly the term, so oligometastatic disease, just to define it clearly for everybody, is, very limited metastatic disease. Some people define that as a certain number of sites of disease, maybe only in one organ or one or two organs. Some people define it as the number of spots in a particular organ. So there's a little bit of heterogeneity in how we define oligometastatic disease. But certainly there is still a lot of interest and ongoing clinical trials to identify women who present with oligometastatic disease at the time of diagnosis, particularly in the HER2 space, in the HER2 positive space, and treat patients with oligometastatic HER2 positive disease with curative intent therapy, so induction chemotherapy, and then to consider either surgery for the breast primary, but also in conjunction with radiotherapy to the metastatic sites, if they can be treated with radiotherapy. In some cases, excision, but mostly these are trials looking at consolidative radiotherapy to oligometastatic disease in combination with curative systemic therapy, to really see if we can identify which patients with oligometastatic disease can be cured, right? But it is a very heterogeneous landscape, right? Because not everybody is going to have an amazing response like you did. And so we do have to select the patients appropriately, because again, all of our therapies are associated with morbidities and impact quality of life. And so we want to be sure that we are doing these aggressive therapies in the women who are most likely to benefit from them. You're right, there's not a lot to talk about it. There's not a lot being talked about at this meeting this year, because we've sort of now in a lull, kind of waiting for these new trials to accrue, and then to bring that data back. We went through the phase of all of the trials for surgery of the primary tumor or surgery for metastatic lesions in kind of the broader population of de novo metastatic breast cancer, not the oligometastatic group. We did not get the results that we'd hoped for in those other randomized controlled trials. It didn't seem like surgery improved survival. It seemed like systemic therapy, getting more effective systemic therapies was the way to go. But now we're entering a new phase where we have these trials specifically focused on women with oligometastatic disease. And so hopefully in a couple of years, we will be hearing more of those results at this meeting.
And in the Monday clinic, if somebody depends, the decision will depend very much on the patient. I have this feeling that some women are happy to have the breast kept, even if it is, mostly if it is like response, total response, but sometimes they feel better if we take the breast or we do conservative treatment. And I think that we have to listen to the patient, because I think if she feels that she's more cured, why not? And if we're not going to harm her, why not? And I think that we put this in a multidisciplinary team meeting, and then we hear the patient, and then we bring the solution to the patient after we discuss. But I know that the clinical trials are not there yet, but we have patients like that every week, right? That want to discuss this, and I think, why not?
Well, I think if you have clear progression of disease in the breast, where your metastatic disease is stable, but the breast is no longer responding, then that's a very reasonable time to be thinking about surgery, because you understand what the goal of surgery then is, and there's a benefit to that surgery. If you have no evidence of disease in the breast or elsewhere in the body, or stable disease everywhere, then it's hard to actually quantify what's the benefit of the surgery. And we know there's potential downsides of surgery. Even when it goes perfectly, there's always a risk of a side effect, right? So I think we do have to be a little bit careful and really ask ourselves, what's the goal of doing surgery in this situation? And in the randomized controlled trials that did test whether there was a survival benefit, there was quality of life data that was included in several of those trials. And women who had surgery did not experience better quality of life than women who did not have surgery. So we often think that we'll feel better, but that doesn't always result in us feeling better, right? So I think we just have to be a little careful. These are really tough conversations, absolutely, and we'd love to think that, you know, that we can do something to contribute, but we need to make sure that we're selecting patients appropriately, and that we're having the conversations that really are able to define what are the goals of the surgery and what are the risks.
I am so sorry because I didn't give you a warning. We're actually over time, so we have to stop here because I have to encourage you to fill out your evaluations. Come back tomorrow for our final educational program, Understanding Diagnostic Tools and Tests for Making Appropriate Treatment Decisions. And thank you very much. Let's give a thanks to our panelists.